Okay, so yesterday we introduced a sort of a theoretical look at an example of a healthcare system, one that may or may not work. So suggesting what could or should be done in the case of trying to resolve a healthcare system, facing the problems that a healthcare system has, be that scarcity, externalities, or in particular what we're looking at in this topic, asymmetric information. So what we introduced yesterday actually has been applied in one country. So we're going to look at what happens in this country, how it runs its healthcare sector, and if there are any sort of benefits for what they do in an Irish context. Clearly there will be some differences between the countries, but we'll also look at some similarities. So the section will probably take maybe 2 classes to go through, and we'll have 9 pieces of material. So what are we looking at achieving with a healthcare system? What is it trying to do? If there's this huge construction that has the health of individuals sort of as its basic building block, but then also has this whole organizational structure, what are we trying to achieve with a health system? Well, one is clearly to improve the health of the population. As we said earlier on in our first lecture, one of the goals of macroeconomic policy is to increase living standards. We, as economists, have a measure of GDP of looking at that. There's a whole host of things that GDP does not measure, and one is health status, the ability to actually enjoy a particular standard of living. So if the healthcare system is part of our overall economy, clearly that should tie into it. The goals of one of our health systems should be to increase living standards. So to improve the health of the population, that your health system is responsive to legitimate needs of the population, that what you actually provide in the face of scarce resources is what actually is needed. So that if you have limited resources, you are allocating them in the most appropriate manner. And then finally, to protect people from serious financial losses because of illness. So we can make maybe glib comparisons between healthcare and other goods, but healthcare is different. In many cases, it's not a choice of whether to buy it or not. In many cases, it's a pure necessity that without it a person would die. And in some cases, the costs can be huge, hundreds of thousands, millions. These are a very small minority of cases, but they do arise. So if people don't have a social backstop, they can face substantial losses, not because of sort of any actions of their own. People losing their own money, it's perfectly, I suppose, acceptable, but people losing out because of ill health is an issue that society must address. So when designing a healthcare system, you can look at the relationship between patients and doctors, the organizational structure, etc. But one of the key issues is where the money comes from. Healthcare makes up about 8% of the Irish economy. It's a huge industry. It makes up 16% of the US economy. So where the money comes to fund the supply of these services is hugely important. So what most countries tend to look at is the financing. Where does the money come from? Don't tend to get directly involved in the doctor-patient relationship, but do get involved in where the money comes from. How does the money get to the supplier from the patient? So the 4 issues that are addressed, or should be addressed, if you're designing a healthcare financing system, are equity, efficiency, effectiveness, and sustainability. Equity is all about fairness. Who pays and who benefits? Where does the money come from? Where does it go? So what is the distribution of the burden or the distribution of the benefit? And then what access barriers do you put in place? Is it free access? Is it subsidized? Do people face the full cost? So equity has to do with fairness on both sides, from raising the funds and then spending it. Who do you get the money from? Who do you give it to? Efficiency has to do with productivity and output. How do you allocate the funds? Do you allocate it to an aggregate unit such as the HSE? Do you break it down by regional units? Do Do you give it to hospitals? Do you give it to particular doctors? Does the money follow the patient? So how do you get the most output for the money you're putting in? So if you have 9 billion to spend, we want the HSE spending it in as effective a way as possible, in an efficient as way as possible, so that the greatest amount of healthcare is provided. The third measure is effectiveness. Does the money actually make a difference? So what are the actual health outcomes? So be it in terms of level of health, measured through maybe life expectancy, child mortality, recovery from particular operations, whatever it might be. So what is the quality of care and the impact on the health status of the population? And then finally, with designing a health financing system, you need to be concerned about sustainability. It's all well and good if the system will work now. What about 25 years down the line, 50 years down the line? Will the system need to be overhauled again? Can the system deal with forecast changes, particularly in terms of the population? An ageing population puts greater strain on the health system. More older people, a greater proportion of the population being older, is a greater proportion of the population more likely to use healthcare services. So can your system survive through demographic changes? So these are what most to be considered. So where does the money come from? Well, there's in general 5 possible sources. But if you're going to raise money for healthcare, where does it come from? One is just direct payments. Like we purchase the vast majority of goods and services. That people pay for what they get. It comes out of their pocket. A second method is that the method of financing can come through employment. That there are a whole host of employment-related benefits. To a lot, we might consider pensions to be an employment-related benefit. Your employer contributing to a pension plan. But in many countries, and even in Ireland, a lot of benefits come through healthcare. Whether that's direct provision of healthcare, as in some countries that would have company hospitals. So huge companies with hundreds of thousands of employees might have their own healthcare facilities. Or the employer deciding to pay for the employee's health. Then you have government financing, which in the most cases comes through general taxes. So the government collects income taxes, corporation taxes, sales taxes, capital taxes, pools all those together, and then hives off a certain portion of that for expenditure in health. So general taxation going to expenditure in health. Then you have insurance, of which there are 2 varieties. One is voluntary private health insurance. A company sets itself up and says to individuals, you pay us an annual insurance premium, we'll cover your healthcare costs. We'll pool all these insurance premiums. Some people will make a claim, others won't. On average, we hope to break even or even better, make a profit. But it is voluntary, up to the individual to choose to participate or not. And in Ireland, we have voluntary private health insurance. About 45% of the population is covered by private health insurance. It used to be a bit higher, but has dropped back during the current downturn. And then you have social insurance. And the issue here is that this is compulsory. It's purchasing insurance, but everybody must do so. So it's a sort of government-mandated purchase of insurance. It can be with a government-run scheme. The social insurer can be the state, or it can be through private companies. That all the government says is you must buy private health insurance, and then have a number of operators who are providing it. And the final method of healthcare financing is medical savings accounts, one we discussed yesterday, where people don't pay tax or don't pay insurance premiums, but their healthcare sort of costs or funds are accumulated in a personal savings account. It's the opposite of pooling. You're not pooling taxes and hiving off some for healthcare. You're not pooling insurance premium and then allocating on the basis of who makes a claim. The money tracks the individual. So different countries have adopted sort of different variations across all these 5 methods. So from the National Health Services model in the UK, which is very much cradle to grave support from the state, coming from tax financing. They raise taxes and then allocate a certain amount to the NHS. You have different social insurance models. Canada and Germany have compulsory social insurance. Everybody must purchase it. In Canada, it's run by the state. In Germany, it's run by private companies. Again, a distinction between where the money is pooled. But in all cases, it's compulsory. In Australia, there's a basic social insurance packet. Everybody must have basic care purchased through insurance. And then if you want additional care, additional cover, you can purchase voluntary private insurance. So it is sort of a combination of the two. But there is a basic minimum which everybody must hit. Then if you choose to go above that, if you want to go for the fancier package, you must pay for it yourself. In the US, the provision of healthcare is mainly through private health insurance. You choose to purchase it yourself. There are some state-run schemes. When we look at some of the stats, we'll see that the funding in the US isn't entirely private. Although it's held up as a model, as a private health insurance model, with the problems that go with that, there is public funding in the US. There are schemes like Medicare and Medicaid dealing with the poor and the elderly. And there's a huge amount of healthcare provided through the armed forces, Army hospitals, Navy hospitals, Air Force hospitals, dealing with current troops and also with veterans. And a final model is these medical savings accounts, which in Singapore are called MediSave, with catastrophic insurance. That you have insurance, but only for a very small number of cases. That you actually get people to pay from their savings accounts for their general healthcare needs. So why should we study Singapore? Well, first of all, where is it? Anyone who's been to Australia via London may stop in Singapore. Singapore is at the tip of the Malay Peninsula. It's about 8,000 miles away. So it's in a different hemisphere. And actually is a small island. So the Malay Peninsula with Thailand and Malaysia. Singapore is a city-state at the bottom. So I think it's about 70 miles across and 20 miles wide. So Singapore is about the size of Louth, slightly bigger than Louth. So in size terms, there is a substantial difference between Ireland over here and Singapore over here. So at the bottom of the Malay Peninsula, tiny little dot at the bottom there. It's completely independent. It's an independent city-state. It did have former colonial rule and has a history similar to Ireland, but is completely independent. So pretty close to Kuala Lumpur, other sort of steps on the road to Australia. So if we make a comparison between the two, is Singapore a useful country to make a comparison? So both, as I said, have a former colonial history, and both actually were ruled by the same colonial power, the British Empire. Ireland gained independence in 1922 with the Declaration of the Free State in 1922 and full independence in the Constitution in 1937. Singapore got its independence in 1965. So we've had a slightly longer independent history, so 43 years. Population-wise, they are quite similar. So Ireland 4.4, in fact the last census tells us that the Irish population is 4.5 million and Singapore about 4.7 million. So in terms of the number of people that their healthcare system has to service, the size of the population is quite similar. So you're looking at providing similar level, similar type of healthcare. One substantial difference is geography. Ireland is 100 times greater in size. So whereas Singapore is all urban, Ireland has a distinction between urban and rural. So clearly there are differences here. Singapore can easily centralise its healthcare services. No matter where it puts it, it's in the centre. It is quite a small area. Whereas in Ireland, We do have a very large or larger area to cover, so much more dispersed population. So in Ireland, the population density is about 60 per square kilometre. In Singapore, it's more than 100 times greater. So if you put a doctor in a square kilometre here, he's got an average of 60 patients. Put a doctor in a square kilometre here, nearly 7,000. So there are differences there. When it comes to GDP, the Singapore economy does have a higher GDP. Well, one, because it has slightly more people, hence more people working. And the Irish figure would have collapsed. I think this is a 2008 figure since then. And in GDP per capita, Singapore is slightly higher. But these would still be some of the richest countries in the world. Like, even if we have gone through a fairly severe recession in Ireland, we still are in the top 20 in the world, and Singapore would be in the top 10. So you are dealing with rich, developed nations with high amounts of resources. On a Human Development Index, looking at freedoms, freedom of speech, civil rights, etc., both score quite highly. Both score above 0.9 in the UN's Human Development Index, and that would be towards the top. So freedoms are quite high in both countries. So there are similarities in size, in wealth, in the Human Development Index, but a key difference is in geography. One is a city-state, it's quite compact, and the second is a country that does have a substantial rural population. So Dublin has grown in size, and other cities have grown in size, but we also have to take into consideration the rural nature of the state. If we just give a quick comparison of some economic indicators, so this is 2008, it was the last year for which I could get data for Singapore. More recent data may be available. And clearly for Ireland, some of these would have changed slightly, but the general trend would be largely the same. So while Singapore was experiencing modest growth, Ireland was contracting. It contracted again in 2009 at an even more alarming level, but has stabilised, but at a lower level. Unemployment in Ireland has grown up to about 14%. Singapore has stayed quite stable, very low. So they do have a difference in unemployment. Inflation in Ireland now is about 2.8%. The figures released yesterday. So it is slightly higher in Singapore, but unemployment would be the key difference. Both are small, open economies. Both engage in huge levels of trade. Relative to the size of their economies, you can see the amount of trade they're undertaking. So both have huge levels of trade and are running trade surpluses. Although because of flows of funds, Ireland has a slight current account deficit. That a lot of the surplus that's generated here does actually leave through net factor income from abroad. But the level of trade in both is huge. So both are small, open economies, very exposed to global patterns. Debt to GDP in 2008, it might have been 31% in Ireland. Unfortunately, we put 62 billion into the banks. So at the end of 2010, that was 94%. So that had trebled in just a couple of years. In Singapore, their debt level has stayed remarkably low. So their government debt as a portion of GDP is quite small. So we do face different constraints. We are running a significant deficit. If you look at the gap between revenue and expenditure, whereas Singapore is running a slight surplus. So the public finances in Ireland are in a far more precarious state. So while the overall size of the economy might be the same, our capacity maybe to change is somewhat different. We're much more constrained, particularly with the EU IMF bailout that sets certain targets that we must hit. So we're not free to set our fiscal policy. We're free in terms of what we choose to do. We can choose to increase income tax. We can choose to increase social welfare. We could choose to, increase corporation tax. But it must all be done within the restrictions of the EU IMF bailout. So that our deficit next year must be 8.6% of GDP. The EU IMF largely don't care how we get there. So all this talk of a loss of sovereignty, that we haven't got a control of our economy, is slightly disingenuous. What we don't have control of is the target. the external supporters don't really care how we get there. So yesterday we had announcements of capital expenditure. Like, none of those cancellations came from the EU and IMF. They simply said, we must have a deficit next year of 8.6% of GDP. How are you going to do it? Are you going to cut capital expenditure? Are you going to cut current expenditure? Are you going to increase taxes? That is entirely up to you. The measures to be introduced still come from Ireland. So while we do have limited scope in terms of the targets, we can make some changes to the actual mix. If you look at the labour force, again, we see some slight differences. The demographics in Singapore are slightly different. So in Ireland, of our population of 4.5 million, we have a labour force of about 2.2 million. In Singapore, of a population of 4.7 million, they have a labour force of about 3 million. So this is one reason why their GDP is higher. They have more people of working age. So a different population structure, different population pyramid. If you look at where the people work, Singapore, perhaps not surprisingly for a city-state, has no agricultural sector of note. There are small pockets of land that are farmed, but it is quite small. The agriculture sector in Ireland has diminished hugely over the past 40 or 50 years, but still provides a small level of employment. So we do have an agricultural sector. Industry is about the same in both, about a quarter of the workforce, and most of the both economies are dominated by services. Health, education, accountancy, law, hairdressing, plumbing, whatever it might be, the provision of services dominate both economies. Nearly 3/4 of the Singapore economy is services, and about 2/3 of the Irish economy. And financial services will be included there. The Irish population is slightly younger. So while Singapore has more people of working age, the Irish population is slightly younger. And it's not because we have fewer older people. In fact, we have more older people. The Irish population is slightly younger because we have more children. We're going through a baby boom at the moment. Record numbers of births in the Irish economy. So that the statistics show that on an annual basis, births are as high as they've ever been. Fertility clearly has fallen. So family size has fallen. But if you look at any given year, the number of births is as high as it's ever been. So about 1/5 of the Irish population is under 15, whereas it's close to maybe 1/6 of the Singapore population. The reason why Singapore has a higher labour force is more people of working age, 2/3 of the Irish population versus more than 3/4 of the Singapore population. But we do have positive demographics with the amount of young people that are being born. The fertility rate in Ireland has dropped, but it still is greater than in Singapore. So we have more births. So 1.85 is the number of births per female. So you're talking average family size of maybe 2.3, 2.4. If you consider those females who aren't in families or those that don't have children. The average fertility rate is 1.85. It's 1.09 in Singapore. So that's probably just about replacement rate. So while the Irish population will grow, it's likely the Singapore population will stay quite static. So the last census has shown that the Irish population has grown, and even growing faster than people had previously thought. The CSO had an estimated population of about 4.45 million. So they'd gone 5 years since the 2006 census, saw the number of births, saw the number of deaths, and were guessing the population. It turned out to be out by 100,000. The birth rate per 1,000 people in Ireland is higher, and our death rate is also higher. But here you can see the reason for population growth. More births than deaths. If we look at some of the health statistics, dealing with similar populations but dealing in different geography, Ireland has over 80,000 nurses for 4.5 million people. Singapore has 20,000 nurses. So we have 4 times more nurses than them. So per 1,000 people, we have about 20 nursing and midwifery personnel. 1 for every 50. For Singapore, it's about 4.5. 1 in every 200. Number of doctors, we have about 12,000 doctors. They have about 6,000 doctors. So we have 4 times as many nurses, twice as many doctors. We've about nearly 3 times, or 2.5 times as many dentists, and nearly 3 times as many chemists. So looking at the provision of health services, we have more people providing healthcare in Ireland. More nurses, more doctors, more dentists, more chemists. So clearly you'd expect that we're healthier. That surely the Irish healthcare system is providing more for Irish people. But if you look at some basic health indicators, who lives longer? People in Singapore have an average life expectancy of 4 years longer. 78 versus 82. 75 to 79 for males, 81 to 85 for females. What is the infant mortality rate? So of live births, per 1,000 live births, how many infants die before the age of 5? A measure of sort of the health of your population, health of mothers, the performance of your healthcare system, and your ability of hospitals to deliver healthy children. Infant mortality rate of 5 per 1,000 in Ireland, just over 2 per 1,000 in Singapore. Of people between 15 and 65, how many people die between the ages of 15 and 65? So if you took 1,000 15-year-olds, how many of them die by the time that group reaches 65? For males, it's 88. In Ireland, for females, 56. In Singapore, it's 83 and 50. So 1,000 15-year-olds, 88 males would be dead in Ireland, 83 in Singapore. So on these basic healthcare sort of statistics, it can be quite difficult to measure the effectiveness of a healthcare system. But on those, the Singapore system performs better. Even though we have 4 times as many nurses, 2 times as many doctors, 2.5 times as many dentists, and 3 times as many chemists, we're spending more than 3.5 or more than 3 times as much per capita. So healthcare expenditure, we're spending over $3,000 per capita. They're spending just over 1,000. This is the healthcare outcomes we're getting for our €3,000. These are the healthcare outcomes they're getting for their €1,000. Clearly, it's not a fair comparison to just say that healthcare expenditure directly leads to healthcare outcomes. There are many more factors: diet, lifestyle, the environment, genetic factors all have a role to play. But there is a distinction between the sort of health indicators in Singapore and the health indicators in Ireland. As a proportion of the Irish economy, healthcare makes up about 8% of GDP. It's 1/12 of the Irish economy. In Singapore, it's less than 4%. So they're devoting 4% of their resources to health. We're devoting 8%. Well, why is that important? Whatever the level of resources you have, we have 92% left for everything else. By spending 8% on health, there's only 92% for everything else. In Singapore, after spending their money on health, they have 96.5% for everything else. The more money you spend on health, the less you must spend on everything else. Your GDP sums to 100. So if you're devoting more of that to healthcare, you must devote less to everything else. Be that education, be that consumption, be that leisure, etc., whatever it might be. As a percentage of government expenditure, healthcare in Ireland is about 1/3, just over, or 30%. In Singapore, it's about 7%. And again, of state revenue, government revenue, the more revenue the government spends on health, the less it has to spend on everything else. So there's 73% left in Ireland after healthcare is provided. There's 93% in Singapore. So it's this opportunity cost that's important. In Ireland, we might feel the opportunity cost was worth it. Is it worth spending $2,000 more per annum on healthcare than Singapore? Well, if you look at health outcomes, It doesn't suggest that it's that they're spending less and getting more. We're spending more and getting less. One issue is, of course, we said we have an older population. Older populations do require greater healthcare provision. So if you look at a sort of a scatter plot of countries, so with the age dependency ratio, percentage of the population over 65, and then healthcare expenditure as a percentage of GDP, you do see this upward positive relationship. So one reason why Ireland spends more is because we have more older people with greater healthcare needs, more people in long-term care, more people who are more susceptible to illness. But if you look at the trend line, you can see that Singapore is below the trend. For their age dependency ratio, they should be spending another couple of percentage of their GDP on healthcare. They are below the trend. Of course, it's not difficult to spot what the extreme outlier is. What country is devoting huge amounts of resources to healthcare relative to its population. So you do have an upward trend. So because we have more older people in Singapore, we would be spending more. But Singapore is below the trend, and substantially below so. If we look at the pattern of healthcare expenditure across the 6 countries we looked at with their 6 different models, Singapore does tend to be a bit of an outlier. That since about the mid-1960s, the proportion of GDP devoted to healthcare in Singapore has been falling or remaining static. This isn't saying that they're spending less on healthcare. Singapore GDP has been growing. So 4% of a small GDP. As GDP grows, 4% of a greater GDP is more money. So they are spending more money on healthcare. It's just the percentage isn't changing. They still have the same proportion available to spend on everything else. If they stay at around 3.5% or 4%, they have 96% to spend on everything else. For the other countries, the healthcare expenditure to GDP ratio has been growing. So the more they spend on health, the less they have to spend on everything else. And the US, again, tends to be a bit of an outlier. The social insurance models of Germany and Canada, the social and voluntary insurance model of the US or Australia, and the NHS in the UK, all have been pulled up. The proportion of their GDP they're devoting to healthcare is increasing. So who does best? Is there a best model we should be following? Well, making rankings of healthcare systems is hugely difficult. How do you judge them? How do you judge the quality of patient care? How do you judge the success of different procedures? How do you judge the availability of care? How do you judge the effectiveness of the money being used? How do you judge the access to different healthcare services? So the World Health Organization has undertaken a ranking of healthcare systems. So the World Healthcare Organization deals with the 194 countries in the world. But they only ranked healthcare systems from first to last once. They did it in 2000. They either decided it was such a hard job they were never to do it again, or it was such a difficult job that getting an accurate ranking was virtually impossible. But they did do it back in 2000 and put huge resources into this ranking of individual health systems. So it does provide a bit of a snapshot of healthcare systems. So one point to note is that this is clearly 11 years ago. A lot of healthcare systems have undergone overhaul since then. So maybe they had a particular ranking back then and changed their system. But it does give us some insight into different systems. So the top system was France. They were spending about 11% of their GDP on healthcare. This is in 2006. So in terms of the amount of resources they were devoting, they were 10th. There was 9 countries devoting a greater share of their GDP to health, but France was coming out ahead of them all. Because France is a wealthy country, it was devoting about $4,000 per capita, so it was coming 8th. And the public-private split, How much of this money was coming through the government? How much of this money was coming through business? Was 80-20. 80% government financing, 20% private financing. So if you look at the top 10, particularly the top 5, it's dominated by European systems. Italy was ranked next, although they might be going through a bit of a financial struggle at the moment. Some smaller countries then followed: San Marino, Andorra, Malta, and then we have Singapore, the 6th best performing health system in the world, based on the World Healthcare Organization rankings. How much money did Singapore devote to healthcare? As a percentage of GDP, it came 173rd. 172 countries devoted more of their resources to healthcare, but yet Singapore came 6th. Again, because of wealth, this is perhaps not a fair comparison. On a per capita basis, Singapore did come 35th. 3.5% of Singapore's huge GDP is greater than 5, 10 or 15% of a poor country's GDP. So when it came to a per capita basis, they were 35th. But still, there were 34 countries spending more per capita, and Singapore came 6th. The one thing to note about Singapore in the top 10 is that it is the only country where this ratio is reversed. For all other countries, public funding dominates. And in fact, the lowest, there's a typo there, is Spain, which is a 72-28 split, or Andorra 70-30. Singapore is the only one that reverses that with a 1/3, 2/3 split. So 1/3 of the money comes from the state, 2/3 comes from private sources, from market-based sources. So it's the only country that reverses that in the top 10. If we extend through the top 20, we can see that in 2000, Ireland came 19th. So we were top 20. As regards the GDP expenditure, we were 38th, and because we're relatively wealthy, we're 10th, about £4,000 per annum. And again in Ireland, you can see that most of the funding comes through the state, about a 4/5, 1/5 split. The country that Fine Gael are proposing we adopt a model from is the Dutch system. So as a percentage of GDP, they're spending more, and per capita they're spending about the same, and they were in 17th place. The one thing to note here is that this is the old Dutch system. The Dutch healthcare system was overhauled between 2004 and 2007. They moved to their social insurance scheme then, and in more recent European comparisons, the Dutch system has been much closer to the top. So it might seem, why are we moving to a system that might see us jump from 19th to 17th? That's not entirely fair. That is an old Dutch system that's been compared there by the WHO. They have completely overhauled their system since then and have moved up in European rankings. Again, the country that spends the most on a per capita basis, the US, comes 37th. There are 36 countries that spend less per capita that perform better. Again, in the US, you can see it's skewed or weighted towards private funding. But although it's held up as a model, as a private healthcare system, you can see that the proportion is 46-54. The government in the US does provide a lot of healthcare. Medicaid, Medicare, the poor and the elderly. The army hospitals make up nearly half of US healthcare provision. And this is the ratio Obama is trying to change. He wants to increase public provision. Because there are a certain amount, proportion of the population that is falling through the cracks in the US. But there is a certain proportion of the population that has no healthcare coverage, just like there is in Ireland. But in the US, there's no public system. In Ireland, every person that's normally resident in the state is entitled to healthcare services. If you live here, you'll get healthcare. If you're dependent on the state system, you may have to wait, but you will get it. About 45% of the population has private health insurance. They get the cost paid by insurance companies. 30% have the medical card. So they get GPs and pharmaceuticals or pharmacy prescriptions covered. 20-25% aren't covered at present, but they do have the backstop that if they do have serious illness, they will be covered by the state. In the US, there's a similar proportion of people not covered, either by the public schemes, Medicare, Medicaid, or the Army schemes, or by private insurance. And it's at that 25% that Obama's proposals are targeted. Clearly, there are some needy cases in there, people who aren't poor enough to benefit from Medicaid, and people who just don't simply have the wealth to be able to afford private health insurance. But in that 25%, there are people who just don't choose to have healthcare coverage. It is a choice. They have the money to afford it, but don't buy insurance. If they have healthcare needs, they'll meet it out of their pockets. So the US, while it's held up as a case in a private healthcare system, it does have elements of public that are quite substantial. So when looking at the last element we look at today is just the design of the Singapore health system. How similar is it to our own? So the Singapore healthcare system is divided across three areas. There's the private commercial sector, there's the not-for-profit voluntary sector, and there's the public government sector. And in Ireland we have all three of those. The state-run hospitals, the not-for-profit voluntary hospitals, and then there's private hospitals. So be it the CUH, the Bonds, the Blackrock Clinic, whatever it might be, we have all of these. In the private sector, you've got private hospitals, private groups, so Beacon Medical Group, Blackrock Clinic, etc. The clinic that was opened up out in Mahon Point, although shortly closed. Owen O'Callaghan has planning permission in for a hospital below on the Jewry site. So you do have private hospitals and groups. And doctors in Singapore are in the private sector. So GPs are businessmen, just as they are in Ireland. They operate their own practices. In the public sector, they have a Ministry for Health and a Department for Health. We could consider these to be sort of the HSE in the Department of Health. We've split it in much the same way. The Ministry of Health is like the HSE. They run the hospitals. So they have primary care units, secondary care units, and tertiary care units. So local health centres, local health clinics, run by the Ministry of Health. They have general hospitals and outpatient clinics, and then specialised care and national centres. National treatment centres, national cancer centres, national rehab centres, whatever it might be. These are run by the Ministry of Health. In Ireland, they're run by the HSE. The Department of Health then takes care of sort of policy, legislation, regulation, enforcement, health promotion, preventative measures. So the Department of Health deals with policy, much as it does here. In Ireland, the Department of Health deals with policy, and the HSE deals with sort of operation. How do you put policy into practice? So the Singapore health system in design is similar to our own. It does have the same settings of public, not-for-profit and private. Its GPs are private. And it has then this breakdown between a government organisation who runs the care side of it, and then a government department who looks after the policy side. Singapore then differs though in what its strategies are. The Singapore system puts a huge weight on incentives and a huge weight on personal responsibility. In Ireland, we don't tend to use incentives, although there are small examples of them being used. And we generally consider it to be a collective or state responsibility. The government should be doing something. The government should be providing the services. The government should be meeting the needs. Whereas in Singapore, they have a sort of an opposite approach, that they first start with personal responsibility. They have a discouragement of overconsumption through cost sharing. So again, we said it's not all public funding. It's 1/3, 2/3. The government is providing 1/3 of all healthcare expenditure in Singapore. But it isn't covering the full cost. It does do a lot of what are called co-payments. We tried to introduce one in Ireland, I think the budget before last. It's still in place. but generated huge controversy for medical card holders that they have to pay a 50-cent per prescription item charge. So under the medical card, your prescriptions, what you require from a chemist is covered. You get your prescription from the doctor, you don't pay him. You go to the chemist, you get your prescription from there, you don't pay the chemist. They're both reimbursed through the GMS scheme, the General Medical Scheme in Ireland. But one fear was happening is that patients were getting prescriptions and not using them. There was anecdotal evidence, particularly of older people, that they were dying and that the families were finding thousands of euro of medicines just being stored up. That the person had a prescription that says, give me 7 tablets of this every week. And they weren't necessarily taking it, but were building it up, perhaps in a precautionary motive. And families were returning this to the HSE. Thousands of euro of medicines to the HSE being returned. And what could the HSE do with it? Dump it. They had no way of vouching what had been done to it. The chemist had given it out, and as soon as it's been given out, it can't be used again. So they wanted to put in place a small incentive for co-payment. So rather than having it free, where you get overconsumption, they introduced a 50-cent charge. But Singapore goes to a much greater extent to that. Virtually everything has co-payments, where you get somebody to think about what they're using. The Singapore system also has a high degree of regulation. The government mightn't have complete control, but it does regulate it. And there is then competition between the public and the private. And the key issue is that they give choice. A patient can choose to go to a public hospital or a private hospital. They're not directed to one or the other. The patient themselves chooses. So what Singapore puts in place is cost sharing. Everybody shares the cost. You have these medical savings accounts, which we look at in more detail. There still is insurance. Saving €1,500 a year isn't going to allow you to cover all your healthcare and costs. So insurance is necessary, but it's catastrophic insurance. And then to raise the funds that the government uses, they have taxation. But they do have subsidies, and they do try to target the taxes so it's raised in an equitable manner. But we'll look at these in more detail when we see how the system actually works and how it actually all works together. So we'll take it up from there next Thursday.